Hello, everybody. Thank you, Arturo, for this invitation. You know how much I appreciate that from you, and you know all the good things I think of you. Anyway, so the topic is risk stratification in patients with FBN1 pathogenic variants, so the part that Diana did not speak about. The first thing I wanted to say is that molecular screening is seen by the cardiologist as the absolute thing. And if you look at what is the efficiency of molecular screening in patients who have complete Marfan syndrome, yes, it completes the diagnosis in 95% of the cases. Now, if you go to less specific syndrome or non-syndromic TAD, which are either familial or occurring in patients with less than 45 years, you see that you find pathogenic variants much less frequently. And more than that, you find the different genes that Diana has been speaking about, but also FBN1, which is a frequent gene in patients with irritable thoracic aortic disease. But, oh, you cannot see my, okay. But what is important is here, you get 10% of variant of unknown significance, which means that the less specific you are in the clinical diagnosis, the more variants of unknown significance you will get with the genetic testing, which will put you in a difficult situation where you cannot say there is a disease or there is no disease, and usually you try to go for a familial screening to try to make some link, but the family is never large enough to make some clear conclusion. And so I think this is a place where we have to make progress, try to decrease the rate of variants of unknown significance. In all these HTAD patients, when you find a variant, then the survival, even free survival without aortic surgery or dissection, is less good than if you have no variant, meaning that the variant has a prognostic value in this population. This problem of who you should test has been discussed in the Vascular European Reference Network. For many of the members of the Vascular are here, including Arturo. And we discussed that patients who had aortic dissection with no hypertension or with hypertension, but who were less than 70 years old, should be referred to a center for testing or decision of testing. Those with thoracic aortic aneurysm who are adults and surely dilated because their Z-score is more than 3.5 should have evaluation, and the absence of hypertension, then the Z-score can be above 2.5. If there is a positive family history, clearly the risk of having a genetic disease is increased, and so that it should be testing. And in the case of syndromic features, you should also go for multidisciplinary evaluation and ectopial antithesis specific. Now going to FBN1. The first, so this is a paper which was made based on the population that we follow. With FBN1 patients, you see more than 150 patients. And the first information here is that you can see that 75% of the population have aortic dissection or surgery, meaning that 24% do not have. So if you have Marfan syndrome, you are not sure that you will have aortic surgery. And the other thing is that the survival now is very good, with 75% of the population surviving until 75 years. Now, if you try to go into some more precise prognosis, then you have different factors that can help you. The first is, are you the proband, the first in who the diagnosis is made, or a relative? Your diagnosis is made because there is familial screening. And you see that the risk of aortic dissection is more when this is a problem than when this is a relative, which is expected because when you know the diagnosis, you do preventive surgery. But also that aortic dissection or surgery is more rare, 50% for relatives compared to 80% in probands. So that probands are more severe, The second thing that was alluded to already by Diana is the difference between males and females, men and women. And you see that the males have aortic dissection or surgery occurring earlier, and to a more important rate than women. And this is true whatever is the type of mutation, and we will come back to that. So the type of mutation, if you can differentiate two types of mutation, the PTCs are mutation with a stop codon, which is appearing so that there is mRNA which is truncated and there is no construction of the protein, so it's haploinsufficient. There is no FBN1, which is synthesized by the diseased allele. This is PTC, and the other one is just the fact that within the protein there is an amino acid which is changed for another amino acid. And you see that according to the fact that the PTC here, so the stop codon, has a prognostic which is less good, or which is worse, with a lower survival than the patients with the FBN1 mutation, which is an in-frame mutation. And when you go into the in-frame mutation, then you can differentiate the rate of RT dissection or surgery with patients who have a loss of cysteine, who have an event rate during their life of around 75%. Those who have addition of cysteine, it's 30%, and in between, the mutation which are not changing the cysteine content of the protein. Why is that so important? Because the cysteines actually are amino acids which are linked one to the other with a strong ligation, and so they are responsible for the three-dimensional structure of the protein, and if you break one of these links, then you modify the three dimension of the protein, and it has a major effect. And then the loss of cysteine variants are very severe phenotype, cardiovascular, ophthalmologic, and skeletal. So addition of cysteine, there are fewer aortic events and less, the forms are globally less severe, except for ophthalmologic features, and there is no cysteine effect, then it's intermediate. But there is no this high prevalence of ophthalmologic disease. So based on that, you can construct a risk for your patients who has a FBN1 mutation. Is he a relative? Is he a proband? Is he a man? Is he a woman? Does he have a PTC variant, in-frame variant, lost cysteine, cysteine addition, or no effect of cysteine? And you can see the event rate, aortic event rate, at the age of 40 and the age of 80. And you can see really that it changes from 100% to 0%, according to the fact that this is a group of mutation on another one. He is a man or a woman. And this is true for the aortic events, but you can also predict the risk of ectopialentis, which is higher when there is an addition of cysteine, high with a loss of cysteine, and much lower when there is no effect on cysteine. And for the scoliosis and the skeletal features, you also have a phenotype which is dependent on the genotype. And I think this is important because then you can see if the patient is going to have surgery during his life or maybe not, and it can help you in many ways. Genotype-phenotype, there is a specific location, which is 2432, exon 24 to 32, which is associated with the neonatal form of the Marfan syndrome. And when you compare those who are 2432, who are in red, with those who are outside this, who are in blue here, you see that actually when this is a stop codon, PTC, there is no difference, which is expected because the protein is not synthesized. When there is an in-frame mutation, there is a difference at the beginning, and this difference is related to the group of loss of cysteine. Because addition of cysteine, there is not much, and no cysteine, there is no much difference. So you see that you can really be more precise in the prognosis of the patient with this. Now, there is not only genetic for the prognosis of your patient. One classical thing is the family history of aortic dissection. And we have been looking in patients with FBN1 mutation and compare those who have aortic dissection within the family and those who had no aortic dissection with the family. and look at what is the risk of those patients with a family history for aortic dissection, which is 8%, to the risk of patients with FBN1 mutation, but with no family of aortic dissection, which is 9%. So there is no difference. And when you look at the risk for surgery, it's the same, 18%, 19%. So when you take all the sporadic cases out, it will remain 1,250 patients with a mutation. And then you compare the risk for aortic dissection in the group with family history, it's 8% versus 8%, so no effect. And the risk for surgery, 18 versus 17, no effect. So there is no evidence that the family history for aortic dissection is a risk factor in patients with FBN1 mutation. There are some phenotypic features which are associated with an increased risk. For example, this is something that we found in patients with FBN1 mutation with a striae. If you have striae, then the risk of having aortic surgery or dissection is greater than if you don't have that. And this is observed also for other mutations, like TGF-beta2 mutation, we saw that also. But this is not true for all the genes, for all the features. For example, there is no link between the presence of ectopia lentis and the risk for aortic dissection in this population. Then there is some aspect of the aorta, which is also important, and this has been reported by the group from Amsterdam. You see that if the aorta is tortuosus, which is tortuosus, you see it, it's clear, then the risk of aortic dissection is increased compared to those who have not aortic tortuosity. So this is also a prognostic factor. There is another one which has been published recently by the group from here, which is the fact that there is an extra aortic aneurysm in patients with FBN1 mutation, and you see that the survival-free of events in those who have no extra aortic aneurysm is better than those who have an extra aortic aneurysm. The extra aortic aneurysm are here, and usually they are not responsible for many complications. We did a similar studies, and we found also that there was a difference, but the difference that actually we observed was only in men. So that was a prognostic factor for men, but not for female. And we found that the type of dilatation that we have out of the aorta may be important for the prognosis of this specific lesion, with aneurysm may require repair, and ectasia, which is diffuse dilation, did not require repair during the follow-up, but these are very small numbers. Another factor which has been published recently by the group of Gain and Julie de Backer is the mitral annular disjunction, which has been associated with the increased risk of aortic dissection of surgery, aortic event, when it is important. You see here the mitral annular disjunction, mitral valve on the muscle. And it is also associated with a greater risk of mitral valve surgery and arrhythmia. And what is interesting also is that when you go back to the genetic of this valvular disease, you see that the prevalence of mitral annular disjunction is greater in those mutations, which is a loss of cystine, which are associated with a greater aortic risk, which may be the substrate for both the disjunction and the aortic event. So we have to find out what is the relationship between the two. And of course, the main prognostic factor is aortic diameter. And the diameter, excuse me. The diameter here below 50, there is no aortic risk, but here the risk is calculated for the next 2 years, which means that one question with the diameter is how long a diameter is valid. Because if you take a diameter of 50 and then you wait for 10 years, then you can say that the diameter of 50 is going to be associated with a risk. But if you measure the aortic diameter in between, it may have increased. So it's not really 50. So in this study, we limited the time of the validity of the diameter to 2 years. And if you do that, then you see that below 50, in patients with FBN1 mutation, the risk is actually very low. So the aortic diameter is not perfect, and there has been some suggestion. I just put the title because if you want to ask questions, you should ask this guy. Proximal aortic longitudinal straits predicts aortic dilatation rate and aortic events in Marfan syndrome. So there are going to be other factors or the parameters that the aortic diameter, which are going to help us in deciding who is at risk or not. But I think this is not yet ready for clinical practice, but we can discuss that. So to conclude, not all patients require surgery. We now have very different population, and we can do individualized risk stratification, and we made progress for that based on the genetics, also on the phenotype, that will help us be more and less aggressive, and that would help us with the counseling of the patients. And I think for FBN1, we made a lot of progress. And conclusion 2, bravo Arturo for all the scientific work. It has been said already many times. You participate in everything. I mean, all the meetings, you participate in something. That's incredible. So you made a huge work, and with a very good mind, which is appreciated by everyone. And you also participate in the creation of the group in the ESA working group on aorta and peripheral vascular disease. I tried to find something that the other will not say. So everybody was focused on science, and I said, a little politics. So this is a little politics. And you made so this is important because I think the aorta will be more in the mind of the people. And as everybody said, and I want to say it again, thank you for your friendship, because it's really a pleasure to be with you and to work with you. Thank you, Arturo.